All right. Hi, everyone. It's 6:30, so we're going to go ahead and get started. Happy first day of spring, and thank you for joining us tonight. So tonight our session is on weight loss and diabetes. Our student speaker is Victor Madormo, who is currently a third-year MD PhD student, I believe, in the program at UNC. So Victor comes to us from the University of South Carolina, where he got his bachelor's degree in biomedical engineering. He is now in his first year of graduate school after completing his first 2 years of medical school here, where he's studying pharmacology, specifically looking at dementia and Alzheimer's. And the professor that he's working with, Dr. Gwen Garden, was actually our first speaker of the series this year, if you came to that session. And so Victor's going to talk for like 10 to 15 minutes. We'll have a short break with questions, and then I'll be back to reintroduce our main speaker for this evening. So Victor, take it away.
Hey, yeah, as Matthew said, my name's Victor. Thank you guys so much for coming. It's really great to see a great turnout. And so, yeah, I'm just going to give a quick introduction on diabetes, and then we'll turn it over to Dr. Klein. There we go. So just as a quick outline of what I'm going to talk about, I'm going to talk about how common diabetes is, some of the symptoms that can kind of give you a hint that you might have diabetes, why do we care about diabetes to begin with, and then how do we diagnose diabetes in the clinic. So how common is it? 1.2 million Americans every year are diagnosed with diabetes. It is one of the most common chronic conditions across America and across the world. 11.6% of Americans have diabetes in the year 2023. The prevalence is increasing. 97 million Americans are living with prediabetes too, which is the stage right before diabetes. That can also come with complications. And 8.7 million Americans do have diabetes and don't know about it, though. And that's 1 in 5 cases do have diabetes but don't know it. So what are the symptoms that we'll kind of see with diabetes is that diabetes is a condition in which your blood sugar is too high, and that's kind of what causes all these different symptoms. Essentially what happens is that because sugar can't move between tissue walls as well as water does, water will kind of tend to follow the sugar. And so when your kidneys are filtering out sugar, that'll pull some of the water as well. And what happens then is frequent urination is a very common sign. Frequently urinating can dehydrate the body, and as a result, you'll need to drink frequently, so you're rather thirsty often. Also, if you think about sugar in your bloodstream, can kind of really make your blood a little sugary and syrupy, and that can kind of slow it down and make your circulation not as good. As a result, if you have a cut or any kind of damage to your tissue and that circulation needs to get there to deliver the nutrients and the oxygen, it'll be slow in doing that, and that can lead to delayed cuts and sores healing, and also just increased infections. Blurred vision is another issue. So like as that water kind of follows that sugar, as it kind of hits the eye, that extra pressure can make your vision blurry as it kind of damages the back of your eye. Another thing is that the sugar in your bloodstream is there because it's not getting into your cells, which Dr. Klein will talk about. But as a result, the cells don't have that sugar that they need to process, and so you're often really tired. But of course, fatigue is not a specific symptom to diabetes. And another common one is unexplained weight loss. So because that sugar isn't getting to those cells, even though it's really in that bloodstream, the cells can think that they are essentially starving, and they can start to degrade the fats, and they'll degrade some of the muscle as well. So there's also unexplained weight loss as well, but usually it's not a good weight loss. It comes from loss of muscle. So while the sugar is in the bloodstream, unfortunately, over time, the sugar can become slightly reactive, and that slightly reactive sugar can bind to your blood vessels. So that's your arteries, your veins, and all the different parts of your body that deliver the blood. And as a result, your blood vessels need to be a little bit flexible in order to actually deliver that blood properly to get the nutrients and the oxygen to where it needs to go. And when that sugar molecule binds to that collagen on the walls of your vessels, it'll become brittle, it'll become stale, it'll damage it, and you'll have a lot of really bad blood vessels as a result of too much sugar in those blood vessels over time. This becomes a big complication, especially for microvessels. So the smaller the blood vessel is, the more this damage is occurring and the more sensitive it is to that. And so different parts of the body that have really small blood vessels will be the ones that are most likely damaged. In your foot has a bunch of really, really small blood vessels in it. And so as your foot blood vessels lose their oxygenation, lose their nutrients, those nerves, which require a lot of energy in order to actually fire, because that's a really energy intensive experience, those will start to become damaged and you can no longer feel your foot if it gets severe enough. And also things such as like ulceration, as that tissue isn't able to heal itself and regenerate, ulcers can form, infections can occur down there, which is why foot maintenance is a really important part of diabetes management as well. Kidneys have a lot of really, really small blood vessels. That's this picture right up there next to the eye. Kidneys have really small blood vessels, and as a result, those get really damaged. And diabetes is a leading cause of chronic kidney disease as a result of it. And then lastly, the eye as well. That glycination on those blood vessels in the eye will cause the eye to kind of degenerate a little bit, and that'll cause diabetic retinopathy, in which your vision kind of becomes blurry, and then little blind spots start to appear as well. Long term, the reason why we do really, really care about this, along with these complications as well, is these three different symptoms: heart attack, stroke, and infection. So if you can think about, your blood is like sugary, it's kind of syrupy, it's harder to pump, it's harder to move. That'll be really hard on your heart. Also, those arteries that are getting damaged and stuff, if that happens to arteries crucial to the heart function, that'll cause heart attack. So diabetes leads to a much greater increased risk in heart attack. Also, small blood vessels in the brain may also become damaged for the same reason, leading to the cutoff of blood supply, leading to stroke. And then also, as talked about before, with the small microvessels in the foot, if those become blocked off and damaged and the foot gets ulcerated, infection can creep in. And if that infection seeds in a way that it, can infect the bone and starts to kill off that tissue, and if that tissue can't heal and starts to die, eventually that tissue can become so deadly that the only way to save the patient is by removing the foot as an amputation. So how do we diagnose diabetes in the clinic? There's a few different tests. So because it's a condition in which there's too much sugar in your blood, the first way, of course, is to look at your blood to see how much sugar there is. Unfortunately, glucose, the sugar in your blood, can fluctuate from many different challenges, such as stress, caffeine, lack of sleep. So it's just always invariable, and especially after eating too. So what's going to be asked is that you fast for 8 hours beforehand, because everyone's blood sugar then should kind of drop to a range of less than 100 milligrams per deciliter, which is just an arbitrary unit, but essentially blood sugars level should drop and remain kind of stably low. If it doesn't, that's a really great sign that you have diabetes. And then prediabetes is if it kind of stays in this middle range between type 2 diabetes and between healthy levels. Non-fasting is another thing that they can just take your blood sugar at any time. It's a snapshot. This, of course, isn't as good because of all that fluctuation in your glucose level. So it's usually not used to determine prediabetes. But if it's greater than 200, that's a really, really high blood sugar level that might be an indication of diabetes. Two other really common tests include an A1C. An A1C is looking at the red blood cells. So these are the cells that deliver oxygen to the different tissues in your body, in your blood. Over time, that sugar that becomes slightly reactive and will bind to different parts of your blood and your collagen, they can start to bind to your red blood cells. People have this healthily. So even healthy people have about a 5% chance that sugar will bind to a red blood cell over time. And so when they take out that blood, they'll look at the red blood cells and they'll look at which proportion actually has a little sugar molecule bound to it. This is a good test to check what the blood sugar levels look like over 3 months, because those red blood cells get turned over every 2 to 3 months, meaning that they degrade and they're replenished, and so there's new ones. And so this can kind of be a really great indication over long term how much sugar is in your bloodstream and how is it reacting to that bloodstream tissue. And then the other way is a glucose tolerance test, which an individual will fast for 8 hours to bring the glucose levels down. They'll be given a sugary drink to bring those glucose levels up and then see how they fall. And then their glucose levels in their sugar blood will be taken again after 2 hours to see did it fall appropriately. And then if it didn't fall appropriately, that's another really good indication that this individual does have diabetes. Prediabetes, which was that middle range, is exactly that. It's that step right before diabetes in which blood sugar levels are just too high, but they're not too high in terms of their type 2 diabetes. This can also come with increased risks for things such as like heart attack and stroke, but most importantly, as would make sense, it leads to an increased risk of type 2 diabetes, usually because this is the first stage. Early treatment and lifestyle changes can actually bring the blood levels back down to healthy levels, preventing or delaying type 2 diabetes altogether. And lastly, the American Diabetes Association recommends that most adults begin screening for diabetes at age 35 or before 35 if there's any kind of additional risk factors or any kind of symptoms that have been noticed. So lastly, here's a couple of resources that are really awesome. Diabetes.org. Diabetes.org, they also give you a diabetes risk test to look at some risk factors. And then also there's a lot of really great free online services such as Mayo Clinic, Cleveland Clinic, just typing in diabetes or any question that you have related to it will give you a lot of awesome information. So that's it. I'll happily take any questions and stuff too. Yeah.
When you were showing the ACL, AC1, and then it had percentages, it's a percentage of what, the sugar level or?
Yeah, that's a really great question. It's the percentage of how many red blood cells. Oh yeah, thank you. The question was, what is the percentage in an A1C test reporting? And it's the percentage of red blood cells that have a sugar molecule bound to it. So like in this example, there's like 6 red blood cells. One of them has a molecule bound to it. So that'd be a 1 in 6 percentage. Yeah, thank you. That's a great question. Yeah. Yeah, that's an awesome question. That's going to be up to epidemiologists and like how they actually run those studies. But essentially, it's usually done like with taking sample sizes and then like extrapolating that out. So like you'll take a sample size of a representative part of America, and then you'll test every single one of their blood sugars to see then, okay, these people have diabetes, they didn't know about it. We're going to extrapolate that data out to apply to the rest of the population. And then, so yeah, last question, and then we'll take a break.
It's like, if you go back farther in time, like, is there a spike somewhere around mid-20th century, late 20th century?
Yeah, that's an awesome question. I don't know off the top of my head. And I would wonder, yeah, if like the levels would fluctuate with things such as like the changing of American diet or the introduction of like computers for sedentary lifestyle. But yeah, I really don't know what the chart looks like ahead of time, but that's an awesome question.
So over time, like we see these steady increase. The interesting thing is actually, and we'll talk about this when I start talking, but they're actually also a rise in type 1 diabetes, which is not necessarily associated with obesity. So there just seems to be a rise slowly, and people attribute the rise of type 2 diabetes to obesity, which we'll talk about, but there also is an increase. So it's just right. And the reasons for why type 1 diabetes is rising is not. We have one more question from the gym. And if we diet, how do we reverse the diet?
Yeah, of course, I'm going to refer to Dr. Klein, but yeah, from my understanding, it can. Yeah.
So certainly lifestyle changes is the first thing that we offer. It is, it can be incredibly successful. So yes, it can do it.
Awesome. Thank you.
We're going to take a quick break while we transition.
If you showed up late and would like to check in.
Okay, thank you, everybody. So we're going to get started with our main presentation for tonight from Dr. Klara Klein. Dr. Klein did her undergraduate degree at Stanford before coming to UNC and staying here throughout medical school, her PhD, and her residency and fellowship as well. She got her PhD here in cellular and molecular physiology, and then graduated from UNC's MD PhD program. And she stayed here at UNC to continue on as an endocrinologist, where she's involved in many clinical trials, specifically focused on diabetes medications. But I won't take too much time away from her, so I'll let you get started. Thank you very much for joining us.
Just let me know if you can't hear me. I don't have a microphone on, but I'm good at projecting. So I'm Klara, as you guys heard. And I'm really just thrilled to be here. I think this is just such a cool session to really take, to give the community the power to understand, disease processes and understand how we as clinicians and scientists think about diseases. And I think, I'm very passionate about diabetes, and, to be able to empower people to understand why we care about diabetes, what it is, and how we treat it, I think is a really special thing. I also, I was just a couple of years ago, 10 years ago or so, that I was in Victor's shoes. So it's pretty cool to be back with the MD PhD program. So my goal today is to be mostly interactive. I'm fairly informal, even though I'm kind of dressed up. If I want you guys to learn, I want you to have fun. So if there is something that I say that doesn't make sense, ask me. Diabetes is an incredibly complicated disease. And so if you have a question, it's not because it's a stupid question, it's because either I didn't explain it well, or it's just a good question and maybe I don't even know the answer. So be interactive. I'm happy to answer questions. Don't be afraid to interrupt me. Okay, so we're going to start with a syllabus for our med school. So this is a brief outline. So I'm going to welcome you, and I'm going to kind of go over a little bit of why we care about diabetes, why it's a big deal. And then in your first year of medical school, we're going to talk about physiology. And I think the best way to understand physiology is to understand what happens when it goes normally. And then type 1 diabetes is a little bit easier to understand, I think. And you'll tell me if I'm right. In our second year, we're going to move into physiology of type 2 diabetes, which is really a more complicated disease. And I think the one that a lot of you are interested in, because it's advertised as weight management, and weight management really plays a role in type 2 diabetes. In third year of medical school, when we're going out to treat people, we're going to go and see understand how we treat type 2 diabetes. And the truth is that it's very complicated. And so I'm really going to focus on these, hot medicines, I'm going to call them the Ozempic-like drugs, because they are revolutionary therapies for the treatment of type 2 diabetes. And I'm not going to talk about anything else other than those medicines. And so we could talk for days and days and days and days about diabetes, and I'd be happy to do that, but we only have a little bit over an hour. Okay, or less than an hour, I don't know. And then in our fourth year, if we have time, we can talk about all the research that we're doing, which is the thing that makes me, that's what I really am passionate about, what I love doing, and how you guys can get involved or have family members or friends, whatever. And so that is the agenda. Okay, so setting the stage. I like to look at pictures, and I hope you can see this, they're a little bit small, but this is a great figure from the International Diabetes Federation. This just demonstrates the global burden of diabetes. And what you can see, maybe with my pointer, can you see this pointer? And maybe I'll use my thing on Zoom. Hopefully you guys can see this. In the world, in 2021, there was 537 million people with diabetes, and that's expected to rise in the next 20 years to 784 million people. It's supposed to rise by 50%. In North America alone, there's 51 million people who are living with diabetes, and that's supposed to increase by 25% to 63 million people. This is diabetes is a disease that affects everyone. And as you heard from Victor, we have great medicines. People with diabetes can live normal lives. Not all those scary things, we can prevent them, but we have to know that you have diabetes and we have to treat it. And I think in general, we should be fairly aggressive in the way that we approach diabetes. In the United States, the stats you can see are different in different places, but this is from the CDC. And it's estimated about 38 million people in the United States live with diabetes. That's 1 in every 10 person. Every person in this room knows someone who has diabetes, whether you know it or not. We're all impacted by this disease. And it is true that 1 in 5 people don't know that they have diabetes. And so this seems shocking, but we have people that come into the hospital every day who have a heart attack, a stroke, come in with kidney disease. They're admitted to the hospital and they've been living with diabetes for years and they had no idea. And this is because, you know, people don't have access to care. They're not getting tested. They don't know that they needed to be screened. And so here is a place where we can empower our communities by saying, this is a disease that impacts a lot of people. You can go to your doctors and say, should I be screened? And most people should be screened. As Victor was saying, 98 million people also live with prediabetes. This is the precursor to diabetes. Not everyone will progress, but a lot of people will progress. And more than 8 in 10 people don't know that they have prediabetes. So again, these are just important statistics to empower you and our community to know that they should be tested for diabetes. So this is the United States as a whole. And I just put this here to let you know that, not surprising, North Carolina is doing just as well as everyone else, which is about a D+, I would say, meaning that we have a lot of diabetes in our community. 12.3% of people in North Carolina have diabetes, and it is a major driver of serious complications, including heart disease, stroke, amputation, end-stage kidney disease, all of these kind of things that are terrifying. You know, oh, it's just diabetes, but diabetes is a precursor to all of these things. It also is incredibly expensive. So in North Carolina, we spend $10.6 billion a year of healthcare dollars on diabetes. So this is, again, this impacts everyone. And it's something that we desperately need to treat. We need to learn how to stop it in its tracks. And it's really an important disease to know about. Okay, so I hope you can appreciate that diabetes is an important thing. Let's kind of talk about the physiology. So we're going into year 1 of medical school. I think that the key to understanding what happens when things go wrong is to understand what happens normally. So really, what is diabetes? And Victor touched on this a little bit, but diabetes is a problem with managing sugar in your system. Okay, so we use this term glucose. Glucose is just sugar. You can see it's just a bag. It's just a bag of sugar. In a person who's not living with diabetes, everyone has glucose in their blood, but it's in a range that is considered normal. So I always like to say, because now we can track our blood sugars. You know, everyone can kind of track your blood sugars. You know, when I go out and celebrate and have a piece of cake when I'm done with this talk, my blood sugar is going to go up. But my body can respond and bring my blood sugar quickly back into a number, into the normal range. And people who are living with diabetes, it's harder for them to bring their blood sugars back into a normal range. And so they end up having a lot of sugar in their bloodstream. And that's called high blood glucose. I might slip into, in my doctor speak, I just want to say out loud that hyperglycemia is just a fancy term to say high blood sugar. And so if I say hyperglycemia, you can call me out. And I can also just tell you that now you know a fancy doctor term, which is hyperglycemia. Okay. So how does the body restore glucose, blood sugar, to the right level? And that's where we have to kind of understand the physiology. So glucose is the body's main source of energy. So your cells, the things that make up your body and your tissues, require glucose. It is essential. So when I go out and I have this cupcake and I eat it, it goes into my stomach, and they're not multiplying, they're being digested, smaller cupcakes. And then it goes into my intestine, and it's absorbed into your bloodstream. Glucose goes into your bloodstream. Okay, so now I've had that cupcake. It's really delicious. And I should say, it's not just cupcakes, right? It's very quickly absorbed as sugar, but complex carbohydrates are broken down into glucose. So things like bread, your fruits, all of that gets into your body as glucose, and your body has to manage it. And the glucose gets into your body, provide you lots of energy. So you can do interesting things like weight lift and give this talk. My brain is using lots of glucose. We need that sugar to drive our bodies. But how does that glucose get into our cells? So this is where we get into kind of the fancy terms, which you've all heard, but probably haven't thought about that much. But so we use a hormone called insulin. And insulin is required for most cells in your body to get sugar into them. And so this is a picture from Wikipedia, which shows the pancreas, which is not a very cute organ. I'm always jealous. My family's all in medicine, and you can take these like the heart and the kidney, and you can put a smiley face on it, and it looks really cute. And the pancreas is, even though it's my favorite organ, is just not that cute. It's, it sits in the middle of your body. It just looks kind of floppy, but it does, it's really a critical organ. And without your pancreas, you won't survive unless you replace them. Anyhow, so if I took that pancreas and I cut it up into tiny, tiny little pieces, and I looked at it under the microscope, this is what you would see. And I'm not going to focus on the cells on the outside of this, but I hope you can appreciate that there's this little circle of cells called an islet. That's an islet of Langerhans, which is a critical for everyone to be utilizing their glucose. In this little collection of cells, there's my favorite cell in the body called the beta cell. And the beta cell is the cell that releases the hormone insulin. And insulin is critical for getting glucose into your cells. And so I'm going to use an analogy, and it's a little bit clunky, but I hope it will help you understand what I'm talking about. So let's think about insulin as a key, okay? And the lock is the insulin receptor. An insulin receptor is just the thing that the insulin goes and binds to. And so think about the insulin going into the receptor like the key is going into the lock. And what it unlocks is this door, which is the glucose transporter. And the thing that you need to think about as a glucose transporter is it's basically just a hole that opens and closes, okay? And when it opens and closes, it lets sugar into your cell. Okay. So when people, when the pancreas is working normally, I go and I eat my cupcake, it gets digested, it goes into the bloodstream. The bloodstream now has more glucose than it likes. And so my pancreas, which is very, very smart, notices that that glucose has gone up. And so it releases insulin. And the insulin goes and it binds. So the insulin is like the key goes to the lock. It unlocks the lock, binds the insulin receptor, and there's signaling to open the door so that glucose can get into the cell. So very simple analogy, but that's basically what happens. And then that glucose can get utilized and you can do these amazing things. We're just, going around doing our thing and our body is doing all this crazy stuff. It's wonderful. So that's how it works normally on a very simplistic level. And so I'm wondering if any of you clever people out there can imagine how this can go wrong. And so the first way that I will talk about it going wrong is in type 1 diabetes. And so if you can imagine, what happens if you just don't have insulin around? And so this is, so I've eaten my cupcake, the blood sugar has gone up, and my body can't make insulin. And what happens is that you start building up sugar, but that sugar can't get into the cell. And so you just keep building up insulin. And so I have 3 children who are out here listening, and they're very into Greek mythology. And so this always reminds me of this story in Greek mythology where someone gets punished, Tantalus gets punished, and he has all this food around him and he can't access it. He keeps reaching for it and he can't access it. So this is the cell, it's all this gorgeous glucose is around. It wants to use this energy and there's no way for that glucose to get into the cell. And so what happens, instead of us being able to do these incredible things like weightlifting and thinking and doing all the things that we do normally, you just starve. And so this is a picture from a review. So insulin was discovered in 1921. And prior to 1921, prior to being able to deliver insulin, people who had type 1 diabetes, they died. It was a death sentence. They starved and people, you have diabetic ketoacidosis. These are complications of diabetes, but basically they starve to death. And so we have had incredible discoveries with insulin so that people who are living with type 1 diabetes can give themselves insulin and live reasonably normal lives. But before that, we couldn't. Without insulin, this would not be possible. And so we'll talk about that just in a second. But I wanted to explain what type 1 diabetes is. So type 1 diabetes is an autoimmune disease. What that means is that your infection-fighting cells, the cells that keep you healthy on a regular, fight whatever bacteria comes in when you brush your teeth and you have a little bacteria goes in, it fights it. Those cells get confused and they start fighting your body instead. And so what happens is that the body starts fighting these beta cells in the pancreas. And so someone who is predisposed to developing type 1 diabetes, that's someone who has a genetic predisposition, something about their, their genes, their DNA make them predisposed to develop type 1 diabetes. And then there's a second hit, and we don't really know what that is. It's probably a virus, maybe it's some environmental trigger. We don't really know, but it sets off this autoimmune cascade and their cells start fighting their beta cells. And so they start developing, they start destroying their beta cells. And so here you can see they're developing markers of type 1 diabetes called antibodies. It's important, again, for those of you who are, who kind of know something about type 1 diabetes, these antibodies are not the things that are actually causing the destruction. They're just markers. So I couldn't go and give you something to bind up all those antibodies and make the diabetes, you make the destruction stop. It's just a marker. So it's very difficult to stop these, to stop the progression of type 1 diabetes, although research is advancing. So what happens is they start to lose their beta cell mass. The cells start to die and they can't make enough insulin to bring their blood sugars back down. And so in the beginning, when they're destroying their beta cells, they can't make enough insulin. They start having dysglycemia or impaired glucose tolerance. Their blood sugars go up a little bit, but not overt diabetes. Eventually, if they destroy all of their beta cells or most of their beta cells, they'll present with the things that Victor was talking about: weight loss, urinating a lot, being very thirsty, blurry vision, and ultimately some people will present with what we call diabetic ketoacidosis. They're extremely, extremely sick. And so type 1 diabetes is a very difficult disease to manage and to understand. And so I just want to touch on this mostly so that you understand the difference between treating type 1 diabetes and treating type 2 diabetes. So as I told you, insulin is required. If you don't have insulin, you can't survive. And so in type 1 diabetes, you have to have insulin. We've known about insulin for 100 years, and there's not been enough advances for us to cure it or find other adjunctive therapies. If you have type 1 diabetes, you have to use insulin. Insulin that we make is very different than the insulin that your body makes. So I eat my cupcake, my blood sugar goes up, it brings the insulin down, and then that insulin is gone. The insulin only lasts for about 6 minutes, and your body is constantly putting it out so that it can manage the glucose. If you have type 1 diabetes, we give insulin, you inject it under your skin, and it lasts for a really long time. So what happens if I give myself insulin? So if I'm going to eat, I have to give myself insulin to treat to cover that meal. But if I cover that meal and I don't eat the whole cupcake, what happens? I have too much insulin around, but my sugar is not going up enough. And so that insulin sticks around and keeps bringing your blood sugar down and down and down. And so people who are living with type 1 diabetes, not only do they have high blood sugars, they also are at very high risk of having low blood sugars because of the extra insulin. So this is a really difficult disease to manage. And we've developed incredible technologies, some of which I'm sure you've heard of. Insulin pumps have been around for a while. This is a continuous infusion of insulin. It makes it much easier for people in general to not have to take out a pen to give themselves insulin. You can just take out your phone or your PDA and say, oh, I'm eating a cupcake that's 30 grams of carbs. I can put my carbs in, and then it will deliver insulin through this little device. It's really amazing. And we've also developed these things called continuous glucose monitors. So these are little patches that go under the skin that people can wear, and it will measure your blood sugar every 5 minutes or so. So you don't have to check your finger stick all the time. And these continuous glucose monitors can talk to the pump, and it can adjust the insulin based on what your blood sugars are doing. That's really a major advance. This is incredible technology, and yet it can't compensate. The technology is not good enough for it to compensate for me eating a cupcake. So if I were to just rely on my pump, which is giving insulin and the CGM, and I ate my cupcake and I didn't bolus, then give an injection through the pump for that cupcake, my blood sugar would be very high. So you can imagine that type 1 diabetes is just a very difficult disease. And I only say that just so that you appreciate that, yep, there's people with type 1 diabetes with this technology, with what we know, the way we can control blood sugars and modify cardiovascular risk, people can live entirely normal lifespans, but the everyday experience is very different than someone who doesn't live with diabetes. It's something they worry about all the time. It's every meal that they eat, they have to think about it. And so I think this is mostly, I think, so the community understands that this is an area where we really need to do a lot of work. There's so much more to do for people who are living with type 1 diabetes. And I want you to remember that in type 1 diabetes, you have to have insulin. In type 2 diabetes, we've made incredible changes with the amount of medicines that we have available to treat type 2 diabetes. And we can, the vast majority of people who have type 2 diabetes do not have to be on insulin, which is really amazing. Okay, that was a lot of information. You finished your first year of medical school. Are there questions? It's okay if there's not, but I don't want you guys to feel like I'm steamrolling you here. Yeah. Yeah, so there is a difference. So there's lots of different kinds. Sure. The question is, if this is a buildup of sugar, what happens when you're born with diabetes? So there are genetic forms of diabetes, and I didn't talk about that, but most people that are born with diabetes, so under a year, most people, not everyone, but most people actually don't have type 1 diabetes. They have some genetic form of diabetes. And the same things apply, right? So there are certain things that you can use to treat genetic forms of diabetes depending on what they have. But most people who are very young who have diabetes are put on insulin. So you can't, it's if you present first day of life with hyperglycemia, they're gonna put you on insulin, and it's very difficult. Can you imagine having all of these babies? That's why I'm not a pediatric endocrinologist. It's a difficult job. But yes, another thing it makes me think. Type 1 diabetes, it used to be thought that type 1 diabetes only happened in children, and that's really changed. We know now that type 1 diabetes can happen in anyone. And maybe some of it is a little bit different. There's a term called latent autoimmune diabetes of adulthood, or LADA, which some of you may have heard of. And a lot of people use LADA and type 1 diabetes interchangeably. It just is, I mostly think of it as type 1 diabetes that develops in people over 30. Sometimes the course, the loss of beta cells, is a little bit slower, but that's not always true. We diagnose people in their 80s with type 1 diabetes, and we diagnose people as young as, very early in life with diabetes. And so it also, I should say that type 1 diabetes also affects anyone. So we think, people really think, oh, type 1 diabetes is a disease of people who are thin. People, obesity affects everyone, right? So people, just because they are living with obesity doesn't mean that they can't also have type 1 diabetes. And I think those are important things for people to understand, because even doctors don't understand that sometimes. So we'll have people who come in, they're diagnosed with type 2 diabetes because they're 45 and they're overweight. And then, over time, their diabetes doesn't get better, and they end up in our clinics, in the endocrinology clinic, and we're diagnosing them with type 1 diabetes. And so those are things to kind of keep in mind. Sure. Yes, this is great. This is why I like having you guys ask questions. So hyperglycemia is just the term for high blood sugar. So someone who has hyperglycemia, depending on the scenario, likely has diabetes or pre-diabetes. So what Victor was talking about, so when you're fasting, I considered a normal fasting blood sugar is under 100. Okay, so you walk into your clinic, you fasted for 8 hours, they get a fasting blood sugar. If your blood sugar is under 100, that's considered normal. If your fasting blood sugar is between 100 and 125, that's technically hyperglycemia, right? That's high blood sugars at fasting. So that would be pre-diabetes. If your fasting blood sugar is above 126 or above, that is called diabetes. So those are kind of terms for the same thing. Hyperglycemia is just a term for high sugar in your blood. I'll also just take a moment to say the hemoglobin A1C is really the test that we use the most to diagnose diabetes. Hemoglobin A1C above 6.5 is considered diabetes, but you have to have 2 different tests. So if you walk into the clinic tomorrow, unless there's evidence that tells me that you've had, that you've had diabetes for a long time, if you have a hemoglobin A1C of 6.6%, I'd have to test it again another time to see, or you could have a hemoglobin A1C of 6.6% and a fasting blood sugar of 126. So you have to have 2 tests that show me that you have diabetes. If your random blood sugar, which Victor talked about, is above 200, it's not, you can't just have a random blood sugar above 200. You have to have a random blood sugar above 200 and symptoms. So if you're coming in and you come to see me and you're peeing all the time, you're having blurry vision, you're having weight loss and your blood sugar is 200, even though you've eaten, I can tell you that you have diabetes because you have diabetes. You have hyperglycemia, high blood sugar, and symptoms. So the diagnosis is also complicated, but it's important to know that there are various ways that we diagnose it, and most of the time we need 2 tests. Good, should we move on? Yeah. These are such great questions. So there's not a way, it's complicated. So there's not really a way to prevent type 1 diabetes. There are very newly approved drugs that delay the onset of type 1 diabetes. So those antibodies, so let's say you had a family member who had type 1 diabetes, we can test to see whether or not you have antibodies. Do we think you're going to progress to have type 1 diabetes? And there are medicines that we can give that can delay the onset of type 1 diabetes by 2 to 4 years. We do not yet have a drug that will prevent diabetes from progressing completely. So it is, and that actually is shockingly is an amazing advance. But the problem is it's very hard to know who to test. So most diabetes, type 1 diabetes, doesn't happen in people who have a family member. Only about 15% happens at type 1 diabetes. Type 2 diabetes is really hereditary, right? It's a lot of genetics that go into it. Type 1 diabetes, you have to have a deep predisposition. And even if you have a predisposition, there's no telling whether or not you're going to progress. So it's a very difficult disease to kind of figure out in terms of who to test, who to treat, all of those, to prevent diabetes from progressing. And there's a lot of research that's going into that. So more to come. There's a lot of studies that are going on for that. Does that make sense? Okay. So we're going on to year 2. We're ready to talk about type 2 diabetes. How else can things go wrong? So we had the situation where we don't have insulin. What happens if your body doesn't respond normally to insulin? And that's really what we're going to talk about on a very basic level about type 2 diabetes. So in this scenario, I eat my cupcake, the sugar goes into my blood, and my blood glucose goes high, and it releases insulin, but my body's not really responding. It's like the key is going in the lock, but it's like not turning really well. And so the glucose can't really get into the cell. And so what does my body do? My body says, oh gosh, my blood sugar is really high. It releases more insulin. And so what happens eventually is that your body, the beta cell, is being smart and releasing more insulin, and it kind of outcompetes and causes the door to open. It binds and unlocks the lock and opens the door. But that requires you to have more insulin. That's called insulin resistance. And what happens over time is that eventually, if you become resistant enough, or your beta cells aren't responding well enough, you develop hyperglycemia or high blood sugar, and you can develop prediabetes and then overt diabetes. And we will go through this many times because it's complicated, and I tried to show you in many different ways. But what you can see here in this graph, which we'll see again on another slide, is that as your insulin resistant goes up, your beta cells can really compensate and make, put out enough insulin so that you don't, you still have normal glucose until a certain point. And at that certain point, your beta cells can't compensate anymore and your blood sugars go up. And that's either because you have so much insulin resistance or your beta cells are not doing enough work. They get tired. So we talked about this, I talked about all these great drugs, these Ozempic-like drugs, weight loss is so great. Where does it fit into all of this? So what causes insulin resistance? Well, the vast majority of type 2 diabetes is caused by obesity, or we started kind of calling it adiposopathy, and that's what that term is here. So obesity-related diabetes. So it says 40 to 70% of type 2 diabetes is caused by, my guess is it's much, much closer to 70% than it is to 40%. We see this every day in our clinics, in the primary care clinics. This is what our community is living with. So what happens is, as people gain weight, the adipose tissue, which is like another organ system, really causes what we call causes lots of inflammation. We always kind of joke in the medical community, it's the inflammatory milieu. It's just a fancy way of, I don't really exactly know what happens, but somehow the signaling just doesn't work as well. There are other mechanisms. Again, it's very complicated, but what you can associate is that living with obesity is associated with insulin resistance. So I'm going to show you this kind of vicious cycle, and I really hope that this goes well, because I messed this slide up a number of times, but this is the way that I would like to think about it. Okay, so in a reasonably, in a normal situation, let's say you have a normal BMI, and you're reasonably insulin sensitive, then your body, your blood sugar goes up, you're relatively insulin sensitive, you release a little bit of insulin. This is the normal cycle. Then as people start to gain weight, they start to get more insulin resistant. Insulin resistance means that your blood sugar is higher, so it requires your beta cells, this pancreas, to release more insulin. So the insulin responds to counter the insulin resistance by giving you more insulin, and that goes and that makes things worse, because with more insulin, there's more weight gain. It gets very complicated. And unfortunately, like I said, at some point, your beta cells are not going to be able to respond. And so what happens is the beta cells fail, either because you become so insulin resistant that it can't put out enough insulin, or the beta cells get tired and they start producing less insulin, and then you start to get hyperglycemia or high blood sugar. So this is a complicated disease, and there's lots of cycles that are interacting with each other, but there is a lot of data to suggest that if we can stop insulin resistance in its tracks, if we can reduce the insulin resistance, then we can disrupt the core pathophysiology, the core problem in diabetes, and reverse it. And so that is what we will talk about when we talk about these new agents and how weight loss impacts diabetes. And so this is type 2 diabetes, insulin resistance. You can't keep up with with the amount of insulin you need to put out, and you get diabetes. So I'll take a pause so that we can talk about the next part of this, which is treatment. And I'll try to go through it a little slower so that you guys are grasping it. Any questions? Yeah.
Like, I guess I'm trying to understand the physiology of how they tie.
Yeah, she's curious about why the beta cells get tired. There's a lot of stress, right? Making hormones requires a lot of energy from these cells. And so as they're starting to put out more and more insulin, they just start to, it causes stress, and they can start to die. Yes. And, it's complicated because the cells can get, you can recover beta cells. So people can show up very sick. And if your blood sugars come back into a normal range, then people can start putting out more insulin. So it's this kind of metabolic stress on these cells. They just stop doing what they're supposed to be doing, and then they can kind of come back. But these are complicated questions. We probably need a beta cell biologist in here to tell us all of these things. Yeah.
How does exercise play into this regulation?
Such a great question. Exercise is super important. So exercise, when you go and you exercise, if you have insulin on board, it can cause you to take up, your muscles are using all this energy. And so if you have high blood sugar, if you go for a walk, or even if you have normal blood sugar, if you go for a walk, you can bring up more glucose into your cells and you can lower your blood sugar. So exercise is really, really important for metabolic health in general. And in people with diabetes, if you exercise, you can take high blood sugar and bring it down. And so, for example, people who are, I think a good example is, people who have gestational diabetes, people who are living with diabetes when they're pregnant, sometimes you tell them, if you eat your lunch, then just, go for a walk and it will help bring your blood sugar down. That's true for everyone. You have your big piece of cake and you feel sleepy. If you go for a walk, you might feel a little bit better. Anyone want to, I've got some aces in the crowd here. I've got an endocrinology fellow and a nephrologist. If they want to add anything, they're welcome. Okay. So how do we approach treatment of type 2 diabetes? So when people walk into my clinic, this is what I think about. And so I'm joking. I put this here mostly because treatment of type 2 diabetes is very complicated. And I think about a lot of different things. I think about the person, when someone comes to sit in front of me, I'm thinking about, when did they die? What kind of diabetes do they have? What comorbidities do they have? What are the things that they can afford? What are the things that are going to be the best for their treatment? It's exceedingly complicated. I don't expect primary care doctors to necessarily get that. This is my job. This is what I do every day. So the idea that we're going to grasp all of that in our mini med school is laughable. But I want you to know that it is not easy to really, to know what's going on, and to, the diabetes therapeutics are advancing and changing very fast. And so there's a lot of things that are available that even the primary care doctors, who are kind of people who are the primary managers of diabetes, don't necessarily know about. And that's really okay. So the goal is not for you to understand all of this. It's just to know that there's a lot of things available. We use a lot of drugs and we think about a lot of different things. So this is just a figure, mostly just to show you that there are a lot of different drugs, a lot of different classes of drugs. Again, the point is not for you to know that they, what they are or what they do. Just know that we use a lot of them. The one that we're going to spend the most time talking today, or the only one we're going to talk about today, are these GLP-1 receptor agonists. They are glucagon-like peptide 1 receptor agonists. It's just a fancy term to tell you that this thing acts like this other hormone, and it acts on the receptor, kind of like the key in the lock. And we'll talk about those. And these are the drugs that we are so excited about, the Ozempic-like drugs. So in type 2 diabetes, these drugs, as I keep alluding to, have really been revolutionary. So these were the first GLP-1 receptor agonist was approved in 2005. And it's really one of these beautiful scientific stories that are just like so, inspiring. So in 1990, scientists wanted to research a venom made by this glia monster as a little reptile, because he noticed that it caused enlargement of the pancreas. And during long periods of fasting, the glia monster will slow their gastric emptying and maintains really nice levels of blood sugar. And so this person found that this molecule, exendin-4, was very similar to a hormone that humans make called glucagon-like peptide 1, so GLP-1. This is a hormone that stimulates the pancreas during times of high blood sugar to cause it to release insulin. It's a very special hormone because it only causes release of insulin when blood sugars are high. That is, that's a really key thing to remember. Good night. It only causes, insulin release when blood sugars are high. So this is, again, insulin. When we give insulin in type 1 diabetes, it is always around, right? So you are at risk of having low blood sugar. With GLP-1 or with these medicines that we're going to talk about, I'm putting this here so you remember, it only causes your body to release insulin when your blood sugar is high. Okay. And so that means that it protects you from having hypoglycemia, which is a problem with treating diabetes. So what's nice about Extendin 4, what they found is that unlike human GLP-1, which lasts for only a couple of minutes, Extendin 4 lasts for hours. And so what these brilliant scientists, which is why we all like these bench to bedside as MD PhDs, is like our dream is to find some great molecule and make some therapeutic that changes people's lives. What they found is, what if we could take this molecule? What if we could make it and give it to people so that we could stimulate more insulin release when their blood sugars are high? And that's exactly what they did. So what does GLP-1 do? What does human GLP-1, glucagon-like peptide 1 do? So in terms of diabetes, the things that are important, I'm highlighting in green the things that are really the things that I want you to think about. So this hormone, when blood sugars are high, so you eat something, it goes into your intestine, your blood sugars are high, your intestine releases this hormone called GLP-1, and it goes to your pancreas and it causes you to release insulin when your blood sugars are high. It also acts on the periphery on your other tissues to to lower insulin resistance, so you respond to that insulin well. So that's really great, right? That helps you that's one of the mechanisms by which someone who's not living with diabetes maintains their blood sugar in a normal range. The other thing that it does, which is really, these things are just, the body is really amazing and it does such cool things. GLP-1 also slows gastric emptying. So what does that mean? When I eat that cupcake and I'm digesting it, GLP-1 is released, so it slows the way that it's digested. So it's making it so not only are you increasing your insulin release, but that glucose is getting into your blood slower because it's causing your stomach to digest it a little bit slower and your intestines to slow. The other thing that we have learned, so it also causes you to stop eating. It increases your satiety. Your mechanism goes to your brain and it says, you've just eaten, you're full, stop eating. Okay, so this is really clever. Your body likes to keep things in a nice cycle. So you eat and it tells you that you're full. So this is how we maintain our blood sugars, one of the mechanisms by which we maintain our blood sugars. But these other things happen too. And when we started using these agents, as they've begun getting more and more powerful, what we've noticed is that it also causes people to...
The library will be closing in 30 minutes at 8 o'clock. If you need assistance, please see a staff member now. The library and the restrooms and the lobby and the meeting rooms will all be closing at 8 o'clock.
It's a perfect stop, so you can just look at Taylor Swift in her video. But what's been amazing is that these drugs, when we start giving them, so what we've developed is a drug that is a very long-acting drug and does all of these things. And when people take these drugs, it makes them lose a lot of weight. And what happens then is we're restoring this cycle that we talked about. So like this is in type 2 diabetes, what we know, we talked about, your beta cells are not doing enough to compensate for this insulin resistance. And when we add these beautiful GLP-1 receptor agonists, these Ozempic-like drugs, it acts on the pancreas so that if your blood sugar is high, it's releasing more insulin. It causes what we call GLP-1 receptor agonist induced insulin release. So again, not going to do it if your blood sugar is normal. So if you are, you're not going to have low blood sugars with these medicines, but if your blood sugar is high, these agents like that will go to that, they'll act like a key and go to the GLP-1 receptor and unlock that GLP-1 receptor and allow signaling so that you release more insulin. And that allows you, it also acts on the insulin resistance, so you respond to that insulin more. So it restores blood sugars, and that's really powerful. But beyond that, it really causes people to lose a lot of weight. So they have more satiety. They are not eating as much. They're fuller. They have some, we can talk about this later, but they have some gastrointestinal distress, a little bit of, they get full and they feel full.
The body produces the GLP-1.
Yeah, in the intestine.
In
Yeah.
No, I have been told that people who have that gastric bypass, so they lose part of their intestines, then also they can become, their diabetes can be cured?
Yes, so these are, I love this. It's such great questions. So yes, it is true. There's huge amounts of data to suggest that gastric bypass can be some of the best ways to reverse diabetes. It is not utilized very much. It probably should be utilized more. It's not. And there are two mechanisms, right? You lose weight, which also improves people's diabetes, but there are changes in your metabolism. And GLP-1, one of those hormones also is changed. So it's good. I must be doing something right. You're getting things. That's great. Okay. Other questions while we're talking about this? Okay. So the nice thing about this is not only you become, yeah. Yeah, so these are really difficult questions. And I think at the end, I hope that I will have left some time for questions. These are the types of questions that we are going to have to grapple with. You know, the answer is probably. So most people that go on these drugs, when you take them off, they have very rapid weight gain. And then they also, I don't know if you read in the news, these medicines also, there's a lot of this feeling of loss of this thing called food noise. So people who are living with obesity, they always talk, they talk, again, this is at least reports that people talk about how they're always thinking about food, and then they take this drug and it just goes away. It's like they've never lived their lives not having this kind of food noise. And so you take people will talk about how you, even days without the drug, they can feel that coming back. And so, yes, we think about these drugs, like if you think about high blood pressure, hypertension, that's not a drug that you would think, why would we take people off of it? It's a chronic disease. These are drugs that we should expect people to be on for their lifetime. Now, if someone comes to me, they've had great success and they said, Klara, I just really want to see what happens when I go off of it. What I would tell them is there is emerging data that maybe resistance training and exercise could prevent some of this rapid weight gain. So my hope is that we'll find a way to not have people on these drugs lifelong, but that is what I counsel my patients. Yeah. Yeah, I think these are good questions that I don't think we exactly know the answer to them. I do think that rapid weight loss is probably, it's kind of, you're in a rock and a hard place, right? So I think it would be better if we could kind of slow it, but we don't have a lot of control. I think getting people, certainly in the case of diabetes, we want people's diabetes to be in control as fast as we can have them. The biggest problem that we have with this rapid weight loss is you're not only losing fat mass, but you're also losing lean muscle mass. And so the key is, this is what I spend my life doing. We are doing lots and lots of clinical trials with this. We have, as you'll see in a couple of slides, we have astounding agents for weight loss. I mean, the weight loss that we're seeing is stuff that we've never seen before with medications. People are losing weight really fast. And we have nutritionists who counsel people, you have to have protein, you have to have exercise. It's very, very difficult. And I don't know, I think in general, these drugs have been around. The drugs that have helped with weight loss a lot have not been around for that long, about 5 years. But these drugs really have been around for a long time. The first was approved in 2005. And in general, I mean, I kind of joke in our community, like I'm waiting for this shoe to drop. These drugs there's just better and better data for them. And so, yes, I worry about it, but I don't know if it's founded, and we probably won't know for some time. I will say that it probably depends on someone's age. A 20-year-old is different than a 70-year-old, is different, than a very sick 45-year-old. You just have to kind of think about the patient that's in front of you. Yeah. Yeah, it's another great question. So in general, they do work pretty well. But there are people who don't respond, and we don't know why people don't respond. But in general, they work for most people. Weight loss is not the same, right? For diabetes, it usually, we get people some people come to us and they're on huge amounts of insulin, right? And we're not necessarily going to get everyone off of insulin. we may reduce their insulin. We have all sorts of, there's all sorts of things that we do. So it's not a cure. It's not going to fix everything. In weight loss, it's a little bit different. I think there are probably more people who don't respond as well for weight loss, and that is not entirely understood why some people might respond and some people don't. But we see it, we do see it, and that's why we're developing more and more potent agents. Okay, so again, with weight loss, I just say, we can move on from this, but as you lose more and more insulin, you become less insulin resistant, and then your body needs to use less insulin. So that's frequently what we'll see in people who are using insulin. So if you come to me and you're on 160 units of insulin and metformin, my first order of operations for someone who has type 2 diabetes, depending on their comorbidities, is usually if they are living with obesity, to put them on one of these agents. And most of the time we can reduce insulin. I had two patients in my clinic on Monday who I had started on these agents, and they have dramatically reduced their insulin. It is truly life-changing. One of them, this is just on Monday. I see patients, one day a week. It's not very much, so people who see patients all the time are, having these incredible experiences. I expect that some of these patients, this patient who's been living on, 100 of units of insulin is going to be off by the next time I see her. So it's amazing. So that just goes to show that these drugs are really wildly effective, and they're even getting more effective. And so I tried to make this so this was really digestible, but I do love a paper. This is a study of a drug called Mounjaro, or tirzepatide. It's not exactly a GLP-1 receptor agonist. It is, but it also does a little bit. So it's a GLP-1 receptor agonist plus something else. So I just say that it's like the next generation of GLP-1 receptor agonists. This is a study that we did in our clinical research unit. I was one of the SURMOUNT-2 investigators. This was published in 2023. And so these are people who have diabetes, who are living with obesity. And I will tell you, so that keep it in the back of your mind, people who have diabetes, who are living with obesity, don't respond to these drugs in terms of weight loss as well as people who don't have diabetes. So if you take a person who has a BMI of 30 or 35, and you put them on these drugs and they don't have diabetes, they're going to lose, on average, more weight than someone who has diabetes who has the same BMI. So this drug, you can see here, this is the study population. The people who were in the trial started with a hemoglobin A1C of 8%. 8% is really what I would consider a threshold where people are at risk for having bad outcomes like retinopathy, eye disease, having kidney disease, having problems with neuropathy. It's really fairly high blood sugars. When you put people on these drugs, Mounjaro or tirzepatide, which is the generic name of it, you can see that over really rapidly, right, 12 weeks, and then by 72 weeks, their hemoglobin A1Cs had dropped to 5.8% on average. That is in the pre-diabetes range. It's astounding. If you look over here, you can look at these, the people who had hemoglobin A1Cs less than 5.7%. That's in the non-diabetes range, less than 5.7%. And nearly 50% of the people that got put on this drug had normalization of their blood sugars. We've never seen anything like this before. It's amazing. Beyond that, these people also lost huge amounts of weight. So what we typically say, what the experts are recommending, is that we kind of change the way that we treat diabetes. Instead of looking at blood sugars, we kind of look at weight. And they suggest that 5 to 15%, really focused on the 15%, can really change the pathophysiology, disrupt the pathophysiology of diabetes. And what you can see here is that in people treated with 15 milligrams of tirzepatide, people living with diabetes lost nearly 15% of their body weight. It's just not anything that we've ever seen before. This is a life-changing drug, and we love them. And I want my people who are living with diabetes to be on these drugs if they can be, and they can tolerate them. And so they're really, really very powerful. And the things that we're testing in clinical trials now, just down the street at UNC, they're even more powerful. So there is really great things to come. And the cherry on top of all of this is that these drugs also modify other things. 5 minutes, okay. I'm almost done, shockingly. Okay. GLP-1 receptor agonists, so these things like Ozempic, Trulicity, these other drugs, they also modify cardiovascular risk. So independent of diabetes and diabetes control, these drugs reduce the risk of cardiovascular events as well as death. Again, this is not important. I don't expect you to have to understand this. We'll look at colors. In this clinical trial, the primary outcome, meaning what they were trying to look at, was what happens when you put people on these drugs? Do they have heart, these are people who are at high risk for having heart attacks and strokes. And they looked at what we call composite outcomes. So the major outcome was 4 outcomes combined: heart attack, fatal heart attack, non-fatal heart attack, stroke, and death from cardiovascular causes. And what you can see is in the blue, people that were on a GLP-1 receptor agonist, they had less of those events than the people that were on placebo. And if you look at death, like what do we care about most? We want people to live. People who are on these drugs died less. It's amazing, right? These are drugs. It's a first diabetes drugs that we have available that really can, there's another one. I don't want to take away from the SGLT2 inhibitors, which I didn't talk about at all, but know that there's another medicine that does really great things. But these 2 drugs, which really came out at the same time, are the first drugs that we have available that I can give to my patients. And I can say, you are at high risk of having a cardiovascular event. If you are on this drug, on average, the likelihood of you dying is less than if you're not on this drug. So if you come to see me and you have heart disease and you have diabetes, these are the drugs that I reach for. So the question is, you come to see me, I want you on one of these drugs. How do I choose which one to be on? So this is where the packaging gets complicated. And then, I made too many slides, and we can talk afterwards, or you are welcome to email me and I'm happy to talk to you about all these things. But I do think it's important as a patient to understand that there are many drugs available and we choose ones for different reasons. So Trulicity, which was the first once weekly medication that we used, is a great medicine for diabetes, but it's not very strong for weight loss. So it's really not marketed as a weight loss drug. So I might use this in a patient who comes to see me who's a little bit on the thinner side, who needs management of their blood sugars, clearly has type 2 diabetes. I might put them on Trulicity, hoping that they're not going to lose a ton of weight. Victoza, or liraglutide, is a once daily injection. That's the one that I just showed you. That was a study that was run by my mentor, John Buse. I think of Victoza really as his drug. So liraglutide, marketed at 1.2 milligrams or 1.8 milligrams, is Victoza. That is the drug that's marketed for diabetes. It's been also tested for weight loss. The same drug, exactly the same drug at a higher dose, 3 milligrams, is marketed as Saxenda, which is a weight loss drug. So when I go to your insurance company, if I'm ordering Saxenda, I'm ordering it for weight loss. If I order Victoza, I'm ordering it for diabetes. This gets more and more complicated. It's really fun. Okay, so Ozempic, it's a game we like to play. So Ozempic is really, I would consider my favorite drug at the moment. It will change, I'm sure, in the coming months, but it's a drug that we know has proven cardiovascular event prevention. It is very good for weight loss. There's going to be new data in just a couple of months that shows it impacts kidney outcomes. This is a great drug. It's a once weekly injection. When it's marketed as Ozempic, the trade name, the generic name is semaglutide. When it's marketed as an injection at 0.5, 1 milligram, or 2 milligrams, it's Ozempic, and that's for diabetes. Same drug, semaglutide, but marketed for obesity at 2.4 milligrams is Wegovy. So when I go to your insurance and I say, I want this for weight loss, I order Wegovy. When I want it for diabetes, I order it as Ozempic. There's another medicine that's also semaglutide, but it's an oral medication called Rybelsus. We don't use it as much because the absorption at the moment is not very good. They're working on mechanisms to make it better. It is going to be a great drug whenever they put it out there. The data is out there. It's a good drug. And so if you can't take an injection, I will order Rybelsus. It's not as great because absorption, you have to take it the right way. And we can talk about that later. Tirzepatide, the study that I just showed you, that's Mounjaro when it's marketed for diabetes. That's 2.5, 5, 7.5, 10, 12.5, and 15. Same exact drug, same exact dosage, marketed as Zepbound for obesity. So these are the games that we play. The problem is that the insurance companies don't always cover things. So what do I want you on? I want you on the drug that I can get you on. So what do? I have wonderful people in my clinic who help us organize to try and get the right drugs. There are reasons why I choose one or the other. You know, if you have heart disease, I want you on Ozempic or Trulicity because those are the ones that are proven, or Victoza. If you have really a lot of, you're living with obesity, you really need a lot of weight loss, and you don't have primary cardiovascular events, then I probably want you on tirzepatide if you have diabetes. But the reality is, I'll take what I can get. So the real challenge is our insurance. This is a huge problem with access. As you all know, these are hot drugs. Lots of people are using them. Lots of people are using them inappropriately. So the people who need them the most, I have patients living with diabetes who are well controlled on these agents, and they cannot find these drugs anywhere because everyone wants them. Insurance companies don't want to pay for them. They're very expensive. And so the last slide I will say, two more things. So one, there are side effects. It can be hard to keep people on the drugs because sometimes people really don't feel good on them. So we really work with people. I would say that if you guys have family members or if you're on these agents and you're having problems with side effects, talk to your doctor. Because there are ways that we can modify these things, you know, slow titrations, also, you know, making it so that you're on in between doses. We have lots of tricks in our pocket. So the last thing I'll say is I spend most of my time doing clinical trials. I love doing research. It really brings me huge amounts of joy to be able to bring, particularly because people who don't have access to these drugs can come to our clinical trials and be part of the change that we're making. They get drugs, we pay for the drugs, we pay them to be part of the study appropriately because they're being compensated for their time. It's really exciting work. We need these clinical trials. We need more agents available. As when there's more drugs, there'll be more competition. They'll be cheaper. We'll have more things to give to people. It's really critical. So the last thing I'll leave you with before I take questions and everyone runs out because it's late, is if you guys are interested in clinical trials, if you have family members, if you have friends who are interested in getting these agents and can't, if you look at the UNC Research for Me, you can use this QR code, or you can email me. I'm happy to talk, and I'll refer you to our coordinators, or you can look at the UNC Research for Me website and look for diabetes or obesity trials. We have a lot of them. Thanks.